The AJAX femur nailing system, short, is commonly indicated for the treatment of intertrochanteric fractures, which occur within the trochanteric region. These are common in older adults, offering rotational and angular stability for stable to highly unstable cases. It is also used for pertrochanteric fractures, located between the greater and lesser trochanters, often extracapsular and unstable. It is also suitable for high subtrochanteric fractures, found below the lesser trochanter but above the femoral shaft. These are challenging due to muscle forces, with the system offering strong intramedullary fixation and potential for augmentation. The AJAX nailing system is an intramedullary implant for unstable trochanteric femoral fractures. It offers an augmentation option. The system allows for easy insertion and it provides angular and rotational stability. It enables early weight bearing. The AJAX nail accommodates both. Cephalic screws work best in strong bones, especially where the outer layer is thick and the inner bone is dense. AJAX blades for osteoporotic bone. It has a medial lateral angle of 6 degrees for insertion at the tip of the greater trochanter for better anatomical. Static or dynamic locking is possible using the aiming arm. The AJAX blade provides rotational and angular stability with a single element. It features a large surface area and an increasing core diameter for maximum compaction and optimal hold in the bone. Position the patient in supine position. Use radiographic ruler under fluoroscopy to measure length and diameter of the nail. Mark the entry point in AP view. It is located on the tip of the greater trochanter in curved extension of medullary cavity. The entry point is in line with the intramedullary canal axis in lateral view. Place the assembly of multi-hole drill sleeve with protection sleeve onto the entry point marked. Insert 3.2 mm guide wire using guide wire introducer in one of the desired holes of multi-hole drill sleeve. Once the guide wire is in place, remove guide wire introducer and multi-hole drill sleeve. Insert the cannulated entry reamer onto the guide wire and start reaming the femur through protection sleeve. Alternatively, we can advance cannulated awl in clockwise motion over the guide wire. Once the primary reaming is done, remove the 3.2 mm guide wire and insert guide wire with ball tip into the cannulated awl. Assemble the flexible reaming shaft with reamer head according to the diameter of selected AJAX nail. Remove the cannulated awl and advance the flexible reamer assembly over the guide wire ball tip. Once the flexible shaft is created, remove the flexible reamer assembly. Assemble the selected AJAX nail on the insertion handle with nail holding bolt using driver for connecting screw. Connect the insertion handle connector on the insertion handle, and advance assembly into the bone. Hammer the slotted hammer onto the insertion handle connector to place the nail inside the femur. Once the desired positioning is achieved, unscrew the insertion handle connector and remove the guide wire with ball tip. Attach the proximal targeting device on the insertion handle and screw it with bolt. Align the protection sleeve with trocar sleeve and 3.2 mm trocar to create AJAX blade assembly. Position the AJAX blade assembly in the distal hole of proximal targeting device. The assembly is in position once we hear a click sound. Punch the bone with 3.2 mm trocar to mark the placement for the guide wire. Remove the 3.2 mm trocar and advance the 3.2 mm threaded guide wire in the bone through the proximal hole of AJAX nail. After conforming under fluoroscopy the position of threaded guide wire in the exact center of femoral head, tap and remove the trocar sleeve, use direct measuring device on the threaded guide wire to determine the length of the AJAX blade. Attach aiming jig for anti-rotation wire to proximal targeting device either in anterior or posterior direction. Insert the drill sleeve into the aiming jig, and advance it into bone. Insert threaded guide wire through drill sleeve into the bone under fluoroscopy. Glide the proximal cortex cannulated drill over the threaded guide wire to open the lateral cortex until the stopper reaches the protection sleeve. Set the stopper according to the measured length on the 10.5 mm reamer. Advance the 10.5 mm reamer over the threaded guide wire until the stopper reaches the protection sleeve. After drilling is complete, remove the proximal cortex cannulated drill. Attach the AJAX blade and impactor by rotating the impactor in anti-clockwise rotation. Insert the AJAX blade assembly over the threaded guide wire into the femur. Use slotted hammer to gently blow the AJAX blade until the stopper reaches the protection sleeve. Confirm the correct positioning of the AJAX blade under fluoroscopy, then lock the AJAX blade by rotating the impactor in clockwise motion. Remove the impactor after locking the AJAX blade. Remove threaded guide wire and aiming jig for anti-rotation wire. Screw compression instrument into AJAX blade through protection sleeve. Rotate the compression instrument in anti-clockwise to compress the femoral neck fracture under fluoroscopy. Unscrew the compression instrument and remove it. Alternatively, we can use cephalic screw instead of AJAX blade. Align the protection sleeve for AJAX cephalic screw with cannulated drill sleeve and 3.2 mm trocar to create the assembly. Follow the same process till insertion of 3.2 mm threaded guide wire. Remove cannulated drill sleeve and use proximal cortex cannulated drill over guide wire through protection sleeve to open lateral femoral cortex. Remove proximal cortex cannulated drill and insert 10.5 mm reamer over threaded guide wire. Remove the 10.5 mm reamer after the required depth is achieved under fluoroscopy. Screw the cephalic screw on the cephalic screw inserter and place the stopper according to the size of cephalic screw. Pass the cephalic screw assembly through the protection sleeve over the threaded guide wire. Once the stopper reaches the protection sleeve, detach cephalic screw from the inserter, keeping in mind the stopper is aligned according to alignment indicator. Remove the inner screw and inserter. Use T-handle screwdriver with wrench rod to insert the inner screw through the nail holding jig from the head of AJAX nail. Inner screw locks the cephalic screw with AJAX nail. Use inner screw holder to fix the end cap of cephalic screw. Once the proximal hole of the AJAX nail is fixed, we move towards the distal hole. Assemble the distal hole assembly with protection sleeve, drill sleeve and 4 mm trocar. Insert the assembly into the hole of the jig according to the size of the nail. Tap the trocar and retrieve it after creating a mark at the bone for the drill bit. Use a 4 mm drill bit to create the bicortical hole in the bone through the AJAX nail. Once the hole is prepared, remove the drill bit and drill sleeve. Insert the measuring device through the protection sleeve to determine the length of the 4.9 mm locking bolt. Use a hexagon screwdriver to insert the 4.9 mm locking bolt through the protection sleeve. After locking bolt fixation, remove the screwdriver and unscrew the proximal targeting device from the insertion handle. Use driver for connecting screw to unscrew the nail holding bolt to release the AJAX nail from the insertion handle. Select the right length of end cap, for cephalic screw, and insert it on the head of AJAX nail using T-handle screwdriver with wrench rod. For AJAX blade, use AJAX nail end cap to lock the nail and cover the gap of AJAX nail. The end cap should be flush to the surface of the bone. This concludes proximal femoral fracture fixation surgery using short AJAX nail. Following the AJAX femur nailing system procedure, immediate post-op care involves managing pain and swelling, keeping dressings clean, and stitches removal around 2 weeks. Weight bearing progresses as guided by healing and the surgeon, moving from assistive devices towards full weight bearing. Early physiotherapy is key for restoring motion and strength, starting with gentle ROM exercises for the lower extremity and avoiding painful movements. Therapeutic exercises begin with basic muscle activation, advancing to strengthening, low-impact cardio, balance, and potentially higher-impact activities as cleared. Regular follow-ups and X-rays monitor healing, and the gradual return to full activities is guided by medical professionals once strength, stability, and pain-free ROM are achieved. Collaboration with a physiotherapist is vital for a personalized plan, and patients should always listen to their bodies and follow instructions.